Welcome back to our discussion of causes of upper extremity weakness and numbness for the PANCE. Let's get back into it. Those are our causes of upper extremity weakness that involves the central nervous system, which causes upper motor neuron findings. Let's move on to our second group of pathologies, and we'll move over to this part of the board. And we will start with Guillain-Barre syndrome. So Guillain-Barre. Guillain-Barre. Now, again, I had to make a mnemonic for this. I remember this from when I was a medical student. I remember the GU for Guillain-Barre stands for goes up. The bar, for some reason, made me think of a trigger. Like if you're going to a saloon in the Wild Wild West, if you go to a bar, there's triggers on your gun. And what this means is that you get weakness that goes up or ascends. So the essential finding in Guillain-Barre is ascending weakness. And how this typically presents is lower extremity weakness and numbness. So they will have numbness, tingling in their feet. They will have difficulty standing and walking long distances, maybe difficulty going upstairs. And then this will progress to upper extremity issues. So upper extremity weakness and tingling. What I mean by trigger is that if you look at the history on the test or in real life, you will find that some weeks prior to this lower extremity weakness, sometime prior to this, they had some illness, usually a GI illness. And this triggered this ascending weakness. Now on the test, the most common cause of this GI issue is going to be Campylobacter. Campylobacter jejuni, which can cause GI distress. It can also cause upper respiratory issues. But there are all sorts of triggers that have been described, and those can include things like surgery, chemo, and even vaccines can cause this. I saw a vaccine ad for a zoster vaccine that warned of causing Guillain-Barre syndrome. So what is Guillain-Barre exactly? Well, Guillain-Barre is actually another demyelinating disorder. So let's call it demyelination, which makes this very similar to multiple sclerosis. So multiple sclerosis was a central nervous system demyelination, whereas Guillain-Barre is a peripheral nervous system demyelinating disorder. And so what that means on a physical exam, you will get lower motor neuron findings. So you will get hyperreflexia to the point that it may even become areflexic. So that is an important finding in GBS, hyperreflexia or even areflexia on physical exam. The diagnosis of this is mainly clinical, but like multiple sclerosis, you can get a CSF analysis, and you will find a distinctive finding on this. So if you look at a CSF analysis, usually they will have a white blood cell count, they will have a protein count, there will be a glucose count, and some sort of band. So on multiple sclerosis, you had the oligoclonal bands. In Guillain-Barre syndrome, you will have normal white blood cell counts. You'll have rather normal glucose and normal bands or zero bands, but the protein will be very elevated. Because the proteins, or type of protein is albumin, is way elevated compared to the white blood cell counts or the cytology. They call this albuminocytologic dissociation. So that sort of is a buzzword for Guillain-Barre. Cytologic dissociation, big word that just means high proteins, normal white blood cell count. Now, just as a review, since we're talking about CSF analysis, one thing that helped me remember this pathology versus, say, bacterial meningitis of the cerebrospinal fluid. Remember, any bacterial cause will increase your white blood cell count. So let's call this GBS. This is our GBS here. And if we're going to have a column called bacterial meningitis. Bacterial meningitis, we're going to find an increased white blood cell count. We're going to have a decreased glucose, and then sort of normal bands and normal protein. But I remember that bacteria need to eat glucose, so the glucose numbers will go down, and of course the white blood cell count will go up because of the bacteria. The treatment for Guillain-Barré is very, very important. Now, as this weakness will ascend from their legs to their upper extremity, it can affect the diaphragm, which will lead to severe respiratory distress. So if a patient comes in and you suspect it's Guillain-Barré and they are going into respiratory distress, you must act pretty quickly and intubate this patient if needed. Now, if they're not in respiratory distress, you do have time to perform pulmonary function tests. That's going to be very important. Now, once you get over the most important part of Guillain-Barré, which is the lung assessment, then you can get to the other treatments, which include IVIG / plasma exchange. Our next topic is botulism. Now, this also presents as weakness, but unlike Guillain-Barré, instead of an ascending weakness, this is a descending weakness. So I remember this as sort of the mirror image of Guillain-Barré. And what the presentation is, someone that comes in usually with eye symptoms, so they will have ptosis, weakness of the face, and that will descend to include the upper extremities, and importantly, as in Guillain-Barré, it can include the lungs. So they can also present with respiratory distress. Now, what is this exactly? Well, this is a toxin formed by Clostridium botulinum, and it will attack the neuromuscular junction. So this is our first neuromuscular junction issue. So I'm going to draw our neuromuscular junction in yellow. So here is our presynaptic membrane, our postsynaptic membrane. And in order for this to work, the acetylcholine has to get from the pre, and it's got to make its way to the post. Now, what the toxin does is that it blocks this release of acetylcholine, so you get quick flaccid paralysis because of this toxin. Exam, again, this is a peripheral nervous system finding, so you will get the lower motor neuron symptoms, and like Guillain-Barré, you can get hyporeflexia and even areflexia. The diagnosis is clinical, and the diagnosis is very important to get right because it's a very sudden and quickly advancing problem. There is a test for toxins in the body fluids. However, this takes quite a while to get, and by the time you get it back, the patient probably is already doing quite badly. The treatment is the antitoxin for botulism. And don't forget, if there is respiratory distress, so with respiratory distress, so intubate as needed. Now, some important bits of history for this. How do you get this toxin? Well, generally it occurs in 3 cases. The first one would be foodborne. So this could happen foodborne. So think preserved foods, canned foods, fermented foods. That will be in the question stem. 2 will be some sort of open wound, especially a wound contaminated by soil. Open wounds can also occur by injecting drugs, so think soil, IV drugs. And the third, believe it or not, can come from Botox injections. So yes, you can get iatrogenic botulism. Let's move on to our next pathology, which is myasthenia gravis. Myasthenia gravis. This is also something I remember my medical school mnemonic for, and that is this. My eyes. Remember, my eyes. Myasthenia stands for my eyes. And the GR stands for grows tired. The reason why this was helpful for me is because the most common presentation would be of ptosis. So the eyelids become very droopy, and you can also get things like double vision. But you can really get weakness of any muscle. So not just the eyelid muscles, you can get upper extremity weakness, and you can get lower extremity weakness. So extremity weakness. What is unique about this weakness in myasthenia gravis is that as you use these muscles, the muscles get more tired. So that's my grows tired portion of this mnemonic. So the key finding in myasthenia gravis is that it grows tired, or it's fatigable. Fatigability. And why does this happen exactly? Well, what is it? Well, this is another neuromuscular junction problem similar to botulism. In order for a neuromuscular junction to work, the acetylcholine has to make its way out of the presynaptic membrane and make it over to this receptor on the postsynaptic side. And what happens in myasthenia gravis is that you get these autoantibodies that block, that's sort of blocking this junction so that the acetylcholine cannot get across to the postsynaptic junction. So that means you will have these acetylcholine receptors, but if a lot of them are already taken up by this autoantibody, you have a limit of acetylcholine that will work. So as you use up those junctions, you will get more and more weak. So physical exam. Again, you will notice the weakness. This is technically a lower motor neuron lesion. Reflexes are generally preserved, actually. Deep tendon reflexes. But if there is going to be a problem, there are descriptions of hyporeflexia in this condition, which makes sense. And on physical exam, you must test the fatigability of this disease. So one way to do that is to have someone repeatedly contract the muscles in question. So if they have weakness of the shoulders, you would have them hold up their arms and see how long they can hold it up. And as their acetylcholine receptors run out of open slots, their shoulders will get weaker and weaker. A diagnosis for this, there are several interesting ways to diagnose this. One is the ice pack test. The ice pack test, in which a patient comes in with ptosis. And one way to see if this is ptosis from myasthenia versus another cause is to put an ice pack on their eye. And if the symptoms resolve, that is a sign that this is myasthenia gravis. Another test is to, for a short while, try to keep as much acetylcholine in this junction as possible. So there is an enzyme called acetylcholinesterase which breaks this down. And there's a drug that stops that effect, and it's called idurphonium. So the idurphonium test is you'll give someone idurphonium, and if their symptoms get better, that is a sign that this is myasthenia. Idurphonium is a very short-acting acetylcholinesterase inhibitor, so it will only last for a short time, not for use for treatment. You can also test for the antibodies. You can test the antibody for myasthenia. Treatment makes a lot of sense. You use acetylcholinesterase inhibitors, namely pyridostigmine, or neostigmine. These are acetylcholinesterase inhibitors, so that keeps more acetylcholine in this junction. You can prescribe chronic immunosuppression, which again seems to be beyond the scope of this exam. And there are certain medications that you should avoid. I can very easily see them testing for this. The two classes that you should know are sedatives, so benzos, opioids, and certain antibiotics, specifically fluoroquinolones and aminoglycosides. So quinolones and aminoglycosides. So you want to avoid sedatives and those certain antibiotics. Now let's move on to our final topic on this discussion, which is polymyositis and dermatomyositis. Polymyositis. Now, when you see polymyositis, what I'd like you to think is proximal myositis. And when you see proximal myositis, I would like you to think polymyositis. Because this is a muscle weakness problem involving just the proximal muscles. So you may come across a test question that has some vague upper and lower extremity weakness, and you might be confused. But if you look for involvement of just shoulders and hips, so if it's involving just shoulders and just hips, that is what we call proximal muscle weakness. And that is how the test will give you a hint that this is polymyositis. It won't affect the hands, it won't affect the ankles, it won't affect the knees or the toes. Dermatomyositis is just polymyositis with the addition of certain skin lesions. Dermatomyositis. And when I see pictures of this, I think it looks like someone that got into a Ultimate Fighting Championship fight. So their eyes will look like they have, these are their eyes. It looks like they have black eyes. Looks like both their eyes have been sort of punched repeatedly. Their hands, their knuckles look like they've been punching something. So see if I can draw a hand here. This is someone's thumb and their index finger, middle finger, ring finger. Their knuckles will have these sort of lesions on them at the MCP joints here. The PIP joints, DIP joints will have these sort of lesions on them. And not to get too graphic, but it honestly looks like they've gotten into a fight. This is the person. It looks like they were put in some sort of rear naked choke because they have these rashes in this sort of V-neck shawl distribution. And so what they name these signs, one is the heliotrope rash. Heliotrope rash. They call these knuckle findings, Groton's papules. These sort of papular lesions on the dorsal surface of the hands at the joints. And this is the shawl sign. This seems to be related to the sun sensitivity of this. When people wear a sort of V-neck shirt, the sun-exposed areas will develop this distinctive rash. I'd like to point out another aspect of this. So this is weakness of the shoulders, weakness of the hips. This is not to be confused with polymyalgia rheumatica, which is painful shoulders and hips. Painful shoulders and hips, especially if it's worse in the morning, is polymyalgia rheumatica. Weakness of the shoulders and hips is more polymyositis. So what is this exactly? What is this polymyositis? Well, let's draw some muscle cells. So these muscle cells come in these groups. And with polymyositis, you get inflammation. So this is an idiopathic inflammatory problem of the endomysium. So in polymyositis, you're getting the endomysium. In dermatomyositis, so let's draw this over here. In dermatomyositis, the inflammation is involving the perimysium. So it's it's the perimysial inflammation, and that is why this is closer to the skin. You will develop these skin findings on dermatomyositis. Now, the diagnosis for polymyositis/dermatomyositis, there are some helpful labs. Creatine kinase is a muscle lab. I find this easy to remember because if you remember, Mark McGuire was a really muscular baseball player in the 90s. He really pushed this creatine. So creatine kinase is a muscle-specific lab that will be elevated. Myoglobin will be elevated. Myoglobin is usually elevated in any sort of muscle damage. And aldolase. Aldolase is an enzyme that breaks down sugars in muscles, and it is elevated in polymyositis and dermatomyositis. The confirmatory diagnosis is a biopsy. So you take a piece of muscle, you look at it under the microscope, and then you will see these characteristic findings. This probably won't be on the test, but the EMG can be helpful for this disease process. Now, the treatment for this is, number one, steroids. So this is an inflammatory process, so steroids is first-line treatment. Now, for the skin findings for dermatomyositis, hydroxychloroquine seems to help. Chloroquine. So it's not very good for COVID-19, but it does seem to help dermatomyositis. And of course, sun protection is key. Sun protection. So to complete this discussion, so we have gone through several different disease processes. To complete this discussion, I'd like to review two findings that it's important for you to stay clear in your head. You might review these before the test. But of all these pathologies that we reviewed, some cause ptosis or eyelid drooping, and some cause facial findings like dysarthria and dysphagia. I think it's helpful to do these sort of categorizations when you're preparing for any test. So of all these lesions that we talked about today, the ones that can cause ptosis or eyelid drooping are TIA stroke can certainly cause that. You want to remember sudden onset and the fact that healthy people do not get strokes on the PANCE, so look for the risk factors such as hypertension, diabetes, smoking, etc. Botulism can present with eyelid drooping. You want to remember the risk factors of open wounds, preserved foods, or getting Botox injections, and myasthenia. And myasthenia can start with eyelid drooping. And remember, fatigability is the key. Fatigability is the key. You grow tired. Now, among these pathologies that we discussed that can cause dysarthria, dysphagia, again, TIA stroke can also cause that. ALS can present with dysarthria and dysphagia because of the voluntary muscles. You're looking for upper motor neuron and lower motor neuron findings on a clinical exam. Guillain-Barre can present with dysarthria, dysphagia, and remember the mnemonic goes up after a trigger, so ascending weakness. So that concludes today's discussion on upper extremity weakness / numbness that can be caused by the complex diseases on the PANCE exam. The next video, we're going to talk about the simple causes, the orthopedic causes of upper extremity weakness and numbness. I'm Will Kang. I'm a practicing orthopedic surgeon, hopefully helping you pass the PANCE exam.